Hello, everyone. Welcome to this evening's webinar from James Cook University. It's an absolute pleasure to have you here, and especially considering we all have fairly busy lives. So appreciate your time this evening. And for those watching it on recording. So my name is Dr. Sam Manger. I'm a GP in Australia, and I'm a clinical GP in practice about two and a half days a week in my primary care, and then an academic GP, and I run the lifestyle medicine postgraduate degrees in the College of Medicine and Dentistry at James Cook University. And that's graduate certificate, graduate diploma, and master degrees, which you hopefully interested in, hence checking out this webinar. I'm also the Vice President and past President of the Australian Society of Lifestyle Medicine. I'm on the RSCGP Committee for the Handbook of Non-Drug Interventions, and some of you may be aware of my podcast called The GP Show, which is an educational podcast for all health professionals. So this is an area I'm very much dedicated to across different fields, and you'll see some of my other sort of work as it goes on, just as an example of the careers and the opportunities within lifestyle medicine, which are considerable and in many directions. And so I really hope you feel sort of inspired by what can be done. And obviously, we got some great other presenters tonight, and they hopefully will inspire you further. So first, I just want to acknowledge the country which we are on. I'm on Gubbi Gubbi land in southeast Queensland tonight, and just acknowledge them and the Indigenous elders past and present. So your other presenters for this evening, the excellent Dr. Emma King, GP and a Master of Lifestyle Medicine alumni, and I'll let her give herself a quick bio, as I will all of our presenters. Dr. Michael Ayling, who's an anaesthetist and an alumni of the Graduate Diploma Program, and Dr. Bethany Howe, who's a GP and Master of Lifestyle Medicine alumni as well. So absolute pleasure to have them here tonight, talk about how they have used the study and the content and the courses to further some aspect of their career in a positive way to themselves and to the patients. That is generally the care, the quintuple aim, improve all the different domains with lifestyle medicine. So what am I going to cover tonight? Now, we did agree that we're going to do an hour talk between us and then 30 minutes Q&A at the end. So we've got an hour and a half with you. Now, I'm going to ask for permission and forgiveness in advance because I think there's very little chance I'm going to get through this in 15 minutes because there are quite a lot of opportunities within lifestyle medicine, and I want to give you a couple of examples of that. So I'll probably be 20 minutes, and then obviously we'll probably eat into the Q&A time just a little bit. But if you have questions, which I hope you do, you can type it into I assume there's a chat or a Q&A box in the Zoom somewhere, and then we'll get to those. And we can just answer them as they come off. And you can also contact me directly if you have further questions. It's sam.manger@jcu.edu.au. So tonight I'm going to give you a link basically to a talk I did a year ago on lifestyle medicine and its role in disease prevention and remission. Then I'm going to spend the vast majority of this talking about different opportunities for lifestyle medicine in varied healthcare settings, primary care, tertiary care, and community care, and the different roles that different health professionals play in all of those, because obviously they're all across all those domains. And then I'm going to just give you a quick slide on the courses at JCU, just give you a bit of a rundown there. All right, so like I said, the link, if you want to see more information, so this is about an hour and a half talk I did in our webinar last year, and it covers what is lifestyle medicine, the reason that we need it, the evidence for prevention, which we have known for a long time is considerable, and then the evidence, which has really become much more to the front of the research and science in the last 8 to 9 to 10 years, slowly building for about 20, 25 years, but really in the last 5 to 8 years, it's really starting to take off. And I'll go through different conditions. So diabetes remission, mental health, like major depression remission, and various other aspects. And emerging things, treatments of schizophrenia, bipolar, dementia, women's health, men's health, and the list goes on and on. So that's on YouTube, and you can check that out, any access. So if you just using Lifestyle as Medicine, a New Era, and James Cook University, and you will find it. So that gives you all the background of lifestyle medicine, because I'm not going to do that tonight. I'm going to talk more about its implementation, its translation from theory and research and pockets of clinical excellence into sort of wider scale and what that looks like. And like I said, there are many paths, whether it's academic or private health, or sort of industry or clinical paths, etc. So I'm going to focus a little bit on primary care first, give you a couple examples, and then talk about, I think I talk about tertiary care next, give you a couple examples of that. And community care is fundamentally about being proactive and engaging with your community, but I'll touch on that briefly as well. So in primary care, there are people often ask me, how will lifestyle medicine enhance my career, right? So it's why you're here. And you can think of it in many sort of layers. And in fact, I'll come back to this slide, but I think it's this slide. Yeah, so this is what we call the onion ring model of lifestyle medicine, which we published about 2 years ago in an international guideline. And so in the center of that is your core skills as a lifestyle medicine practitioner. So your ability to assess and prescribe based on the lifestyle and social determinants, which does include some more sort of emerging testing, like say microbiome and things like that, and some evidence-based supplements, though we don't focus fully on that. So we get excellent at these sort of mind-body interventions, the sleep, physical activity, nutrition, social connection, social prescribing, and so on. We also really enhance our health coaching skills, behavior change skills, which is both health coaching, but also thinking about the built environment and how we can utilize that and also technology to improve behavior change and engagement in a meaningful way with our patients or clients that we're serving. So that's the sort of core clinical aspect of it, which every practitioner can take into any part of their job for benefit. And we've had obviously GPs and non-GP specialists and podiatrists and physios and OTs and psychologists and pharmacists, all these different backgrounds have come into this course. And we know it's relevant because they tell us how relevant it is. So that's those core skills. And you can become accredited health coach in our program at JCU with Hakansa. So we offer pathways to become legitimate in these ways. But then we also zoom out and then we think about the actual models of care with which lifestyle medicine um, can enhance, but also needs to flourish in to be done well. We have to advance the way that we deliver care, whether it's primary care, hospital care, and so on. So that is the evolution and the advancement of medicine and so on. So we have to continue that in this direction. And within that, there are lots of different options. So as I say, you can bring your lifestyle medicine to your job as current, improve your health coaching skills and your skills across lifestyle and social determinants. But there are also opportunities in intensive lifestyle medicine or creating subspecialist lifestyle medicine clinics with some diabetes reversal, aka metabolic health, heart disease, dementia care, or longevity programs, of which I'll give you a couple of examples. Women's health, there's a lot of sort of perimenopausal lifestyle medicine clinics popping up now, which I think is great. There's men's lifestyle medicine programs popping up, and so on and so forth. So you can sort of subspecialize and be an example of that. But then you've also got the way you deliver care as well. So it's not just one-on-one care. You can do group appointments, and that I'll show you some examples of that, both in what are called shared medical appointments, but also what are called medical yarn-ups in Indigenous people with Indigenous people. Social prescribing, which is a key part, and how that engages at different levels. As I say, health coaching or lived experience support workers, which again, I'm going to show you a couple models of. How we can integrate and actually create genuine interdisciplinary care. And that's a real challenge in our current structure, but it is possible. And always you can create if you need to. And then how would we bring in the digital workforce, the digital aspects, AI, such a big aspect. So we absolutely integrate learning and how to use AI, both in clinical and research practice now more and more. So, and then of course, as I say, proactively, the engagement of health professional to community, whether it's schools, workplaces, or community settings. And there's a lot more there's a lot more I could say there. Didn't mean to close that. Apologies. Okay. So now this in primary care, this is where primary care is going. So if you're thinking, well, is that going to happen? Yeah. So this is the intent with primary care, as you can see here, Australia's primary healthcare 10-year plan, is to shift primary care from a reactive system to a proactive system, from a biomedical system to a biopsychosocial, cultural, spiritual system, to go from episodic care to regularly engaged care and preventative care as well. From going from measuring services, like how many appointments do we do, to outcomes, like what impact are we actually having. So this is the direction that lifestyle medicine is taking. This is the same direction that healthcare broadly is going. And so the solutions, we actually have a lot of them. And I don't mean we've got all the solutions, obviously not. But the point is we've got the ingredients to create the differences that need to happen. And when we think about how to implement lifestyle medicine, we there are various ways to do it. One of the ways is what they call process map, where you map out the patient journey, for example, and then you think, well, where can I implement lifestyle medicine at these different intersections in a patient's journey? So when they book the appointment, should they be sent out more information? Can we get the goal setting and the reflections and the preparation for the appointment going right off the bat? Can we get things going in the waiting room? Can we use that space and time? How do we enhance the consult? How do we do interdisciplinary care? How do we follow up with people from a behavior change point of view? What technology do we use to do that? And so on and so forth. There's obviously certain areas which may be high yield. Early life, childhood, and pregnancy are two really obvious ones that if we improve the things there, then we're going to have a massive impact on the trajectory. So there are ways that you can think about this from a process, but also from a utility or yield point of view. Or you can just say, well, I'm just going to create a whole new system. And that's similar to what Dr. Stephen Liu and others have done with Everlab, which is very much a preventative health business that's very successful, considerable startup and listed on Forbes. And I think one of the fastest growing startups in Australia over the last 2 to 3 years. And it's fundamentally focused on, and you can listen to a podcast we did very recently on it. And he talks very regularly about how lifestyle medicine is a key part of what they do. It's one of the main parts of what they do, assessing, prescribing, and then working in other preventative care as well. And this is a sort of creative entrepreneurism which is going to lead healthcare in the future. And the intensive lifestyle medicine clinics, just to give you an example of some research papers, this is a program run by a bunch of neurologists, and they're covering people with ADHD, with cognitive impairment like dementia, with post-concussion syndrome, so a number of things, problems. This is their program, their NeuroFit Brain program, and you can see here sleep, Mediterranean diet, exercise coaching, meditation, omega-3 supplementations, brain training. Here are all the things in the middle that it's affecting, the mechanisms and the pathways, and BDNF, growth factor, inflammation going down, etc., etc. You can listen to me talk about more about that in the YouTube talk. But and then you can see the benefits, lower anxiety, better mood, better memory, better processing speed. So that's an example. There's also diabetes, like I said, metabolic clinics. This is a randomized controlled trial where they compared an intensive lifestyle medicine clinic to your standard diabetes clinic. And what they saw was after 12 months, the remission in the intensive lifestyle medicine was 61% of the people left that intervention in remission of diabetes versus 12% in control. And 1.5 less medications versus 1.5 more medications in the other group. So 3 medication difference after 12 months. This is the power of that sort of approach. This is just a screenshot of one of my own patients, which is similar. They came in for me for second opinion, HbA1c of 11 within 3 months down to 6.1 using a lifestyle medicine approach. And as I say, there are high yield areas with high levels of research like antenatal care, where we know lifestyle medicine interventions reduces complications 25% in mothers, 55% in neonates, which is huge. There are also deprescribing clinics, which is somewhat core to lifestyle medicine because a lot of people who are coming off medication or want to come off medication need to have a more intensive lifestyle medicine approach. So often people are seeing you both if you're a GP or a specialist in this areas. And that's an option for some people as well. I mentioned shared medical appointments. Essentially, these are group appointments. There's lots of research to show that this improves outcomes, satisfaction, and so on. This is another way that people are bringing in lifestyle medicine into different settings, whether it's chronic disease, antenatal care, or indeed in Indigenous First Nation people, where this work being done and still being done now across the PHNs in rural and remote Australia. 8-week lifestyle medicine group program showed that almost 30% of women who'd had diabetes for more than 10 years went into remission, which is incredible outcome just because you do it as a group. So that's very powerful. There are a number of online programs that different people in the field have created. Vively, which Dr. Michelle Woolhouse, who's a fellow of lifestyle medicine, has developed with Tim Viron, which is a very successful metabolic health business. Optimal Me, which is a sort of lifestyle medicine preconception program by Professor Helena Teed. The LIFT program, which is a lifestyle medicine positive psychology mental health program developed by Professor Darren Morton. So people have taken their passion and their expertise in this field, and they've gone off and done something quite impressive with it. This is an example of community events where this picture on the right, the man in the middle with no hair, is Dr. Glenn Davies, and he's a GP in New Zealand and a lifestyle medicine practitioner. And they create these where they have online groups to support each other, practical events, all about reversing diabetes in the community. Again, there's evidence for these programs. We talk about that in the course. And some pilots happening in Australia, but a major shift in New Zealand where there's now health coaches and health improvement practitioners offered in almost every primary care centre now in New Zealand. It's an EOI, but over 500 practices now have health coaches in them, which I think is a very good move, and the evidence is looking strong. So this across different benefits, across outcomes, across satisfaction, across reducing psychotropic prescribing, and so on. We're currently in discussions about rolling out some of that in Australia. So there are bigger systemic models of care changes that we can aim for and advocate for. Now, in tertiary hospitals, tertiary centres like hospitals, again, if you think about a patient process, that's one way to think about it, which I've talked about, sort of showing you here. There are obviously other ways to think about this, but so before a patient goes in, prehab for surgery, but not just physical activity. I mean, it's patchy prehab across Australia and most countries. Most of the time, it's physical activity prehab, which is obviously super important. There's sometimes some nutrition in there, and that's often where it stops. Luckily, we've got Dr. Michael Ailing tonight, who's an anaesthetist and has an interest in this area and has developed the skills in various ways. And so we'll hear a bit more about that. But this is a obvious window of opportunity for patients to feel motivated to improve their various domains. And once they've got going, a lot of people typically start when they start to feel so much better. There's during admission, obviously, there's after admission, there's outpatient lifestyle medicine inclusion. And I put a photo here of Dr. Lizzie Elliott, another GP who is another alumni in our course. And she has, for her master's project, developed an outpatient shared medical appointments program in chronic disease. And she developed it, uh, evaluated it, is now publishing it, and is doing the rounds, speaking at various conferences about it, which I think is wonderful. And it's just showing, and the outcomes were the patients were so happy about having this opportunity to improve these aspects of their life. I'm talking about staff education, which is just always important. Now, we don't have to talk about this slide, but the simple point I'm making here is that you can see there's meta-analyses, randomized control trials, systematic reviews, and so on. The point is there's actually quite a lot of research where we start to look at how to optimize, surgical outcomes or hospital outcomes. So we should use it. This is a company that I am developing with another person called SurgeReady, which is a sort of online prehab program. Again, it's fundamentally based on lifestyle medicine. Just an example. I'm not going to talk about that for sake of time. The other aspect is obviously there's hospitals and then there's primary care or there's home. But many of us will know about the major bed blocks occurring in hospitals. And part of the solution, which has come from both private industry and the public sector, is to create what are called low acuity facilities. And these are being rolled out certainly across Queensland at the moment, and I think more broadly. And they're a midway place between these two aspects. And this person in the photo is Dr. Kuljit Singh, who's a lifestyle medicine practitioner, social prescribing expert. She's on the board of ASLM. Well, she soon will be. And she running these low acuity facilities and developing social prescribing programs within the facilities to start engaging people in the community, empowering them, connecting them, so that we're not just discharging people off to a socially and potentially lifestyle detrimental environment. We start working on that whilst in these centres. I mentioned education of medical staff and students and wherever you can put it in. Obviously there's medical schools, there's colleges of all different types. There's obviously just developed private education, and then there's education, like I said, at hospitals and for companies. And this is so needed. It's so needed. Major reviews here, systematic reviews which have looked at the quality of nutritional education or other aspects of lifestyle within these programs. It shows it's basically insufficient. It just doesn't. There's just not enough. Full stop. Right. The importance of having programs like ours. Obviously, we want to go higher upstream though eventually. Now, academic careers. So I've mentioned clinical careers, of which there are many. I've mentioned sort of business careers or entrepreneurial style careers. And now to talk about research, lecturing, and policy. So there's just so many different avenues that you can take across all of these things. There is so much research that needs to be done. I've mentioned a few areas already, but we could pick any condition, autoimmune disease or endometriosis and lifestyle medicine, which luckily Bethany is going to show you some of her master project, which was a scoping review of lifestyle medicine interventions in endometriosis. So there's so much important research that needs to be done. This is just an example. It's a major international guideline we published a couple of years ago because lifestyle psychiatry is kind of my area. Here's another paper that we published on the bottom, which just got published yesterday, which is a big deal. There's about 15 countries involved in sort of defining lifestyle psychiatry as a subspecialty of lifestyle medicine. And this is now internationally recognized. The American Psychiatric Association conference this year, which I flew over for and spoke at, was called lifestyle psychiatry. So these major institutions are now adopting lifestyle medicine. We don't have to fear that this is still a fringe thing. It's becoming much more mainstream. Again, just published 2 days ago was this social prescribing in the Australian context from the Victorian Uni and Australian Health Policy Collaboration, which I was also on the expert advisory group for. And again, this is a policy document about bringing social prescribing in a meaningful way nationally. So again, there are opportunities that are lying all around the place to have a role or an influence in this field. Consulting. So you can consult with private enterprises, with medical and allied health colleges, for private health insurers, for governments. Again, I'm sorry I'm talking about myself, but Toga Health, which is a new private company on the block, building a 70-bed private mental health facility in inner Western Sydney. And I've been consulting with them for some time now, and it is one of the most rewarding parts of the work that I do, seeing the innovation, the bringing in of lifestyle and holistic care into the hospital experience. And then, this is some other colleagues I've worked with over the years, different professors, Lise Jacker and others across Australia, who you work with philanthropists and help them consult on where should they invest their money to make a difference in healthcare. So you can again work across different sectors. There are immediate opportunities. Now you can take this whatever direction you want. I decided that I wanted to educate the health professional or help the health profession because I think I don't need to work on the grassroots thing. I think the public are generally wanting this more and more. But I've always been very passionate about health professional education. So that's where my podcast is focused on health professionals. But if you want to go full public, you can go Peter Attia and Andrew Huberman if you want. That's fine. But we can give you the skills and the evidence base to form that. And I think these two are quite reputable. I'm not criticizing them. I think these two are quite good. And then there are other ways. Dr. G over here has written a book and so on and so forth. So there are options. And this is, like I say, this is relevant to all health professionals. There's me on the left some years ago, pre-beard, pre-grey hairs, with Dr. Linda Barron, who's a psychiatrist. And this is us running lifestyle medicine programs in the long stay mental health units. And it was, an incredibly rewarding interdisciplinary experience and outcome. Kim Pointer in the middle here, who's a very well-regarded practice nurse, but also a very well-regarded health coach, and she now consults PHNs and primary cares on how to bring health coaching into their practice. Someone like Cam McDonald, who's both an exercise physiologist and a dietitian, bringing personalized lifestyle medicine across the scene. Jenny Kirshner, who's a pharmacist and has developed the PALS program, the social isolation. I've seen some great programs from pharmacists. Pharmacy, in the AKFARM, so pharmacy, like food programs, exercise programs, social prescribing programs. There's a real potential in pharmacists because of the flexibility of the business model. And then, John Stevens, who's also a nurse, but an academic, sociologist, and his work is having a huge impact as well. So every professional can contribute to this field. But really, there's no one size fits all. So how you use these ingredients and take it in the direction you want to take it that you care about, that's more the problem. The problem usually I have is the students come in and they have too many ideas. They have so many different ways they want to impact the healthcare system. So actually, it's refining that is sometimes the key. But Mother Teresa always has a good couple insights. And really, she sums it up here. And my advice always is to, you've got these big visions possibly, but you've got to break them down into steps and start small, take those first steps, but do it with passion, and doors open up quite quickly. All right, so that's pretty much me. Last slide. Yes, about 22 minutes. Apologies. Um, so lifestyle medicine at James University. We're in the College of Medicine and Dentistry, graduate certificate, graduate diplomas, masters, and fundamentally we are here to help you catalyze your career. I meet with every diploma and master students one-on-one to help them shape their direction that they want to go. I try and support and network them as best as I can, as well as the other academics and the rest of the team at JCU. We've got other GPs, dietitians, health coaches, EPs, and so on and so forth. Um, all health professionals can apply part-time, full-time options. We're on trimesters now, 3 intakes a year, shorter subjects, so quicker degrees, which is great. Commonwealth supported places, recognition of prior learning, pretty much for most professionals because I recognize there's a lot of expertise out there. And those who finish the masters or use any of it can contribute it too, but a master's is equivalent to a full fellowship with the Australian Society of Lifestyle Medicine, so you get that as well. And as I said earlier, there's accredited health coaching pathways and pathways to PhDs. So if you're interested, please do contact me, sam.manger@jcu.edu. And now I'm going to wrap up and we're going to bring on Dr. Emma King.
My name's Emma King. I'm a GP and a lifestyle medicine physician working in the Adelaide Hills. I'm going to, I guess, talk through a more personal journey through the Masters of Lifestyle Medicine, why I chose it, how I found it, and how it's shaping my career now. Just an acknowledgement that I'm on Paramount country. I live and work on Paramount country and wanted to acknowledge the people who've taken care of the land for millennia and pay respects to elders. One of the reasons that I did lifestyle medicine is because it was really important to me to take care of the people who live in the community that I live in, and be able to provide holistic care. My background is mostly in rural and also remote general practice. I've worked rurally in South Australia, but also in the Northern Territory in East Arnhem Land and in Aboriginal health. I completed the Masters of Lifestyle Medicine at the beginning of the year and did my earlier studies in South Australia. In a former life, I was a scientist, and I'm a GP fellow and also a fellow of the Lifestyle Medicine College as well. I've done a bit of teaching. I enjoy teaching. I still visit registrars, and I've taught medical students and junior doctors. And in a former life, I was a management consultant and molecular biologist. And as I said, I live and work in a rural area. This is a photo of a walk I take in the mornings. Um, I believe that despite a chaotic presentation that may exist in the media around primary care in Australia, that lifestyle and environment and technology will all meet to empower people to become active participants in their own health, that holistic health, personalized medicine will all become the norm. And the reason for that is because it's what people want. People seek that. And as Sam has just been talking about, um, people are responding at grassroots by creating different models of care and trying to bring to folks that more holistic model of care. I was interested in lifestyle medicine because it's grounded in evidence. It is evidence-based, and it is an adjunct to traditional medicine. It's holistic, so it assesses the whole person. It looks at their social, cultural, and environmental context first, meets them where they are, understands what their goals are, and then uses those lifestyle leaders to prevent disease, and also treat it and reverse it. It aims to create total well-being and flourishing, rather than addressing acute illness and delivering sick care. It's patient-driven, and so it focuses on a whole approach to assist the patient to derive their goals, support. So it's based in coaching. It isn't just delivered by one profession. It uses multidisciplinary teams. It's a whole system approach. And because it's a movement for change. And so I wanted to be amongst people who were generating that change and moving Australia's health system in a direction for holistic care. So Sam's talked through this already, but essentially it's a whole system. It looks at lifestyle medicine pillars, but it also focuses on behavioural science and the social and environmental context of the patient. It looks at people at an individual level, but then also at a policy level. So particularly models of care, which Sam has talked about quite a lot tonight. So when I did my master's, I wanted to look at models of care, and consistently in looking at papers that studied models of care, there were three key components that always existed. So looking at the social context of the patient, using behavioural science to support them in generating change themselves, and then lifestyle medicine pillars. And so the pillars of lifestyle medicine are evolving, but there are consistently 6 lifestyle medicine pillars. I chose to do my master's at JCU because I wanted a really deep immersion in the detail. I wanted to really understand how to better support patients, use health coaching. I wanted to understand the detail of each of those areas of lifestyle medicine. And the content in the master's is very, very rich. So it certainly provided that. There is a keystone unit in coaching and behavioural medicine. And as Sam mentioned, it provides a platform for people to go on and complete their health coaching accreditation if they want to. It also focuses on models of care, as you will have just seen. It looks at how to deliver lifestyle medicine and holistic medicine, which I was particularly interested in. And because if you complete the master's, the capstone project is 6 months of research. And so in being involved that, I wanted to contribute to the evidence base and build knowledge in what is an emerging discipline. If you complete the master's, it also leads to attainment of fellowship. And so that also allows you to be a part of a dynamic, positive, actively growing group and make those connections with others that are similarly interested in lifestyle medicine. And because the course leadership was just so excellent, and I had been familiar with Sam's work on the GP show, the lecturers are outstanding, really knowledgeable, very supportive, and always accessible when you're, wanting to discuss really detailed work. In terms of where it's taken me, I wanted to be able to integrate lifestyle medicine in my patient consult. And so it's that innate requirement. So every patient I see, consider in terms of those 3 key things. What is their context? How do we help them achieve their goals? And what are the levers of lifestyle medicine that we can pull that will help them prevent disease, stabilize disease, or even reverse it in some cases? I've used my new knowledge and qualifications to continue to develop my own practice and my service offering. So at the moment, I'm just working on specific services for assessment, management of patients, both in person and online, and working on developing a website to better deliver lifestyle medicine. being part of a multidisciplinary community, so the Society of Lifestyle Medicine, and also other groups like the GP Special Interest Group on for social prescribing, has meant that I've met lots of other people and been involved in a number of projects around education materials. And on this slide, I've just got a photo of the recent Check magazine. It's a GP magazine aimed at educating general practitioners. The November issue was on lifestyle medicine. A lot of the articles around social prescribing, and the article that I developed for that is on mind body medicine. And that was a really fantastic project to be a part of, and then again allowed me to learn more about lifestyle medicine and make connections with other similarly minded people. Um, There is an enormous amount of support and resources. So if you join the college as a member and also from JCU, there's access to information on lifestyle medicine, but also with other partners. So, for example, companies like Vively that supply continuous glucose monitoring, other organizations that provide services in lifestyle medicine. And a lot of research and development work. So my own master's was on models of care in primary care. I was particularly interested in how you deliver care um, to patients in the dominant model in Australia, which is essentially a fee-for-service model. So how do you spend longer with people? How do you deliver effective coaching and support? And so that was a scoping review looking at the evidence and identifying key characteristics for how to do that well in Australia. And I also supported a fellow student as a second author to develop research on digital nudging in lifestyle medicine. And the other significant advantage is that there's a lot of work that you do on your own self-care. So it's transformed, I guess, how I care for myself and my family. The website that I'm working on is really just looking at different tiers of service and around delivering lifestyle medicine, which I'm calling Foundations to Flourishing. It will support different levels of coaching and different degrees of detail in the assessment and prescription of lifestyle medicine pillars. The JCU Masters has enabled me to do that. I've been involved in more training and education roles. I would really love to be involved more in policy and advisory. And because of the work that I'm doing with the College of Lifestyle Medicine, which involves developing some educational material for other practitioners, and I've also started doing some consulting for Everlab, which Bethany is going to talk about a little bit soon. It's enabling me to be more involved at a policy level as well and champion models of care in primary care. And so evolve general practice to a stage where we're able to provide holistic care to all patients. I did include some slides here on a case example on the case that I published in the Check magazine. I can see that we don't have lots of time, but essentially just wanted to point out that the case was on a real patient or an amalgam of patients. So a typical patient who might present with stress and burnout and is interested in lifestyle medicine. And so the Lifestyle Medicine Masters has really just provided a framework to be able to establish the social context of the patient. So really understand what she means, what her life is like, how her relationships work, obligations affect her life, understanding sources of support, what her self-care practices are, how she derives meaning, purpose, and connection, and what coping mechanisms are. And then the behavioral science around health coaching teaches us that patients are more motivated for change when they have autonomy, competence, and relatedness. And so health coaching enables the practitioner to help them find that, use tools like motivational interviewing and the trans theoretical model for change to understand their stage of change, identify barriers and enablers, form goals towards making their own behavioral changes. So this particular patient is feeling very stressed. They're very busy, a parent who works and also studies. Their partner works away. They are up to date with their preventive care, but they've expressed that they're not exercising or eating as well as they would like, and they're very, very stressed, drinking a little bit more and starting to smoke again. And so, again, lifestyle medicine teaches us how to assess this across all of the pillars, which include stress management, social connection, addiction medicine, nutritional medicine, physical activity, and sleep medicine. And so some simple behavioral strategies include understanding how important these are to the patient and how confident they are in changing them. That can then allow us to do more detailed assessments using validated tools of each of these pillars and develop very specific prescriptions. In this patient's case, she was very interested in addressing her stress and didn't feel confident in doing so. And so the next stage was focusing in on that for her. Michael is going to talk a lot more about mind body techniques. What the lifestyle medicine masters will teach you is what some of those are, how to apply those in patient consults and develop management plans, how to understand a patient's motivations and goals, but also using techniques like positive psychology to understand whether their commitments are valued aligned and help them make practical adjustments to the things that might be adding to their stress. And then specific techniques for inducing a relaxation response, including meditation, breath work, guided imagery, yoga, etc. And then there are things that you can do in the consult as well. So a simple example in this case is box breathing. So after getting consent from the patient, doing some breathing with a really effective way to reduce stress, and there was developing some goals that they would like to work on. So for anybody who's considering doing the masters, I would say that the course is incredibly practical and the content is very, very deep. It's academically driven, and so there's a lot of evidence that you can use in your practice in each of those areas of lifestyle medicine. You join a very supportive community through the Society of Lifestyle Medicine, JCU, and many of their partners. And the lifestyle medicine skills that you gain are very practical and you can implement them directly in your one-on-one practice. It also shapes your identity as a clinician beyond your one-on-one practice and can allow a lot of different career paths and also improve your own well-being. Thank you very much for listening.
My name's Michael Ayling. I'm a consultant anaesthetist in the Southern Highlands of New South Wales. I don't have a slide presentation. I'm just going to talk to the subjects. So it might be a bit of a break from we used to call it Death by Light Pro in one of my careers, which was in the Australian Army. So I joined the Army in medical school, and they sponsored me for the latter half of my 6-year degree and spent the next 5 years in the regular Army in uniform. And why this is somehow relevant is because it's an unusual kind of medicine. It's in an aviation regiment where I was posted in Townsville for 3 years, so I've had a lot of Townsville time. I was largely occupational medicine, so looking at boring things like nasal polyps from paint pot resins and whether a pilot can reach the controls after a rib fracture to to optical illusions with night vision and how that's affected by having a cold, and it's very unusual things, all the way through to nuclear, biological, chemical defense measures, but prior to the Iraq invasion. Um, and so I was used to delivering medical care in unusual environments on base and also on deployment in East Timor and other countries, and scraping things together and making do with what you have, and dealing with incomplete equipment, disaster care in Banda Aceh, and a variety of different things. So I had a different background to the usual school, med school, residency, unaccredited jobs, get an accredited job, basically never leave school in that sense. So after I left the regular army, I joined the reserves, and it was very interesting going back to being a registrar from a career where most people called me sir, and I was a major, and then I get some consultant 2 years older than me thinking his opinion on Afghanistan is more invalid because he knows more anesthetics than I do. So that was a bit of an interesting, humbling experience. So I got through anesthetics training. I found that very interesting, but it is very technical. A lot of patients can't pronounce it. A lot of patients don't even know your doctors, and the drugs make that very easy. And ever since 1846, when the first anesthetic was publicly demonstrated, it's allowed the physician side of what would become anesthesia to sort of fall by the way as our drugs become more and more effective and shorter acting. Um, Patients can feel a bit processed in like a factory. So I'd always having had that background of looking for different ways to do things, and I'd started to miss my time as a regiment medical officer, I had 600 people in my regiment who were all my patients, whether I'd seen them or not, with all different sorts of problems. Most of them were healthy people, obviously, but some people were not. Some people had waivers, and that continuity of care is completely lacking in anesthesia. And you almost forget that you're a doctor yourself, and you get treated that way, and then people, you teach people how to treat you, so it's a reciprocal process. And then once I was on a friend's house. I was actually on a boat with a 5G signal on my phone. I thought there are people who can work on a boat like this. They don't have to be in a hospital doing stuff, or we've got this Zoom thing as well, uh, just before COVID actually. And then I started looking for something interesting, and I already listened to podcasts which Sam's already put up there with Huberman and Peter Attia, and I'd used to listen to Peter Attia quite a lot because I share his passion for statistics, maybe not quite so intensely as Peter Attia does, I should say, but the really looking for the evidence base for things, because there's a lot of rubbish out there. If you look up, I mean, it's difficult to find a better term, but if you look up the term lifestyle medicine, you can find everything from what we do with an evidence base to people on Instagram recommending coffee enemas. And so there really was a bit of a barrier to establishing that case for it. And I found Googling, looking for something to study so I could pursue something like this. And I found uh, the advertising page for the inaugural course at JCU. So I enrolled for that. I enrolled in the graduate diploma course. I had done a graduate diploma in economics prior to that, pretty much as a hobby. And my wife sort of rolled her eyes, are you doing another thing? And so I did that, and with a lot of my other army time and some other RPL, managed to get the fellowship of the Australian Society of Lifestyle Medicine, and then the American so-called Board of Lifestyle Medicine. Um, and then I found that study quite interesting. I could fit it in anywhere because it's all online. I can do the study whenever I wanted, in cafes, coffee shops, whenever I could fit something. I'd do stuff from my iPad, my phone, my laptop. It was very, very, very well set up, very well supported. Um, and it really, really enabled me to get the work done and have a full-time career with 3 children, and my wife working as well. So that's just the side of the practicalities of getting the study done. I found the community very interesting, and it really, um, I was really looking for a way to incorporate it. I had initially these dreams of doing some part-time lifestyle medicine clinic, but in the context of my anesthesia, it became difficult to sort of make that happen, especially where I live fairly remotely. So I started really just incorporating it as impromptu lifestyle medicine into my anesthetic pre-admission clinics. And to be honest, it's made it. I sort of get a bit emotional sometimes, but studying lifestyle medicine has made me a doctor again. And when I sit down, I see this patient sit there with all the background of what I've studied with the course. I see the whole patient again rather than the person attached to the gallbladder soon to be removed. And that's not to say that you have to do a lifestyle medicine to see that case. And there is a certain hubris that can go with discovering some sort of, you find an arrogant surgeon's discovered being compassionate and thinks they're the first person ever to discover that. No, not at all. But in my case, it was enabled me to get a broader understanding of the patient's concerns. And now when I see patients, I just say to them, what do you think my job is? And they go, oh, it's to knock me out. I said, no, I've got 3 jobs. The first 2 are obvious: keep you alive, keep you safe. And the third one is to chase away your fears and anxieties. And the skills of coaching, reflective listening, motivational interviewing have been invaluable to facilitating that for my patients in the clinic. So I've been able to give more practical advice on smoking, on dietary interventions for all of the components of metabolic syndrome. If you don't know, so if you've got raised triglycerides, hypertension, raised body weight, what are the others? Insulin resistance, and with the pressures of time, one other. Sorry, there's 5 of them. I think it's LDL. So if they get any of those components, they, an increased perioperative risk. And there's some things we can do, and you find a lot of patients haven't been educated because they've seen doctors who can't or won't educate them, or don't have the time to educate them, or the patients haven't felt that they've been heard. And I've been able to give people some hints. So, for example, even just the distinction between diabetes, pre-diabetes, and insulin resistance, just to let them know why they are in fact manifestations of the same condition, and to explain that and draw it out for them, and talk about what insulin receptors are, how they work, how they can increase the sensitivity, explain what food swamps are, explain choices about shopping around the outside of the supermarket. And this is all in the context of a 10-minute session. I've also been using the skills to develop prehabilitation. Now, that's been a bit of a Sisyphean task. If you know, Sisyphus was the ancient Greek king who eventually went to Hades and has to roll a boulder up, and it would roll down and up and down forever for his sins. And so there's been a bit of politics at my main hospital, but essentially, I think Ronald Reagan had a plaque on his desk saying you can accomplish anything if you don't care who gets the credit. So I've decided to give the surgeons the credit and think that it was their idea all along. And so they came to me saying, oh, we want to get something for prehab. I said, well, amazing. I've only been asking for it for the last 3 years. So we're gradually working with some of the clinical streams at Campbelltown Public Hospital, which is my main tertiary hospital, to introduce them. Mainly where the best evidence is abdominal surgery, and then at the other more advanced hospitals, lung surgery, but it applies throughout. And and again, you can talk to the patients explaining what fitness is, which is an increase in the number and quality of mitochondria. That's it. And explaining why that is the case, and why that's useful to them in surgery, why it's useful to be, if you can run a certain distance before you start to get acidemic, it's the same way for being operated on for a certain duration or intensity before you started getting acidemic, and before your enzymes start suffering from that acidosis and consequent acidemia from the increased lactate. So the educational part's interesting. Also, cancer patients in pre-admission, some of them are quite pleasantly surprised that they come along for a consultation, and when I'm going to talk about how they're going to be knocked out and how they're going to get their pain relief, and they leave with an exercise prescription. And that's based on, fairly large meta-analysis, which was dealing with breast cancer, showing a 29% decrease in tumor recurrence and metastasis, and mortality in patients with breast cancer if they meet WHO recommended exercise guidelines for moderately vigorous exercise, 150 minutes a week, whether they lose weight or not. And then if they look at me funny, I draw out some of the putative reasons why that may be the case. And so they've got some education, and I said, look, get over this surgery now, but when you finish that, this is why I think it's really important that you start to build up your exercise. So I have one case history. I work in a number of hospitals, and I run a clinical lead for a pre-admission clinic for 2 of them. I had a 39-year-old male in the smaller of the 2 public hospitals I work at. He was due for an ankle resurfacing operation. He had rheumatoid arthritis, atrial fibrillation, lived with his mother. He was metabolically, what we used to sort of harshly call a potato with toothpicks in it. So just the very, very the Pickwickian man. His BMI was 41, and therefore was unable to have surgery at that hospital. They had a cut-off of 40 for anything other than cataracts or minor gastroscopies or something. So I engaged him. We Zoomed about every 10 days for about 15 minutes, exchanged emails, text messages. I gave him some education on exercise and the reason for it, and we worked out something he could do around his pain, and explained that the exercise is not about losing calories, burning calories. That exercise is only about 20%, or calorie burning from exercise is only about 20% of weight loss. The rest of it is the magic that the metabolic chain of events that's begun by exercise, which alters your cues to appetite. So people who exercise eat less food and they lose weight. That's 80% of it, and that feeds into sleep, feeds into glycemic control, feeds into cortisol levels, sympathetic activation. If you could put exercise in a pill, we'd all be gazillionaires. Anyway, over 3 months, we put his operation off for 3 months. And he came back 3 months later. He lost 16 kilograms, and I said, "Easy, Tiger. That's far too much. Don't want you to lose any more than that over a year, not 3 months, because of the risk of essentially going into what I call a famine mode. Your metabolic rate slows down, your thyroxine falls down, and you start eating like a bird and not losing weight." That said, initially, then that's coming from his first reaction in the clinic when he said, "I reckon I can get my BMI to 39.9." I said, "Well, is that the whole point of it, though? Do you just want to get your BMI to 39.9, or you want to have a better life?" And then we went through just addressing all of the 6 pillars of his life, and one by one, and working through different things we could do to address his stress levels, to address his drinking levels, his exercise, his diet, his activity, and so that was a positive story. And he came back 3 months later, had his operation. And so that was interesting. So also patients in the anaesthetic bay. I mean, just today, I had another talk to give earlier today, so I handed over to my head of department, but I had a patient having a lap nephrectomy, and I was talking to the registrar and the anaesthetic nurse about clinical hypnosis, which I'll talk about in a second. And um, the patient was sort of listening, and he said, "Oh, does that work for smoking?" And he said, "Bear in mind, this guy's just about to go and have his kidney removed, so pretty major surgery." I said, "Yeah, it does. Tell me more." And he said, "Well, they told me 2 days ago I had to give up smoking." I said, "Do you want to give up smoking?" He said, "Yes." "Okay, so are you really convinced that you've smoked your last cigarette 2 days ago, you never want to smoke again?" He said, "I don't ever want to smoke again." So he's 36. That's okay. So I could tell me about your first smoke. Tell me about your first cigarette. How did it taste? How did it make you feel? Why did you do it? Then we established some ideas, so that he was running on old software. He did it to be cool and look good for the girls and some status. And I said, "But you're 36 now, so you're running on old software that's no longer relevant to your life. So that reason no longer applies. You don't need to." And "Oh, why did you smoke now?" Because, "Oh, it relaxes me." I said, "Oh, so you believe it relaxes you." So we're just shifting from "it relaxes me" to "you believe it relaxes me," from a reality to a belief. And then I asked him if he wanted to be hypnotized, if he had ever been hypnotized, if he recognized that this is a collaboration. I can't hypnotize you. I can just guide you to hypnotize yourself to enter this state that's similar to meditation, but a very, very awake state. And he said yes. So cut a long story short, I induced him. He was very deep hypnotized. We went through some metaphors that we use in hypnotherapy. And 12 minutes later, he's awake, 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 burst into tears. He's just so grateful. And then I said, "And when we come into the operating theatre, if you're looking a bit jittery, like, you can enter this state anytime you like." So he came in, he's looking around. You know, when you go to move someone's hand and they do it too much, it just means they're anxious. So I just said, "Look at me, look at me, look at me. Take a deep breath in and sleep." And off he went, straight off. And then so he was awake, actually, but we just used the word sleep because we don't have a better word. And that enables me to give lower pre-induction doses of drugs, so better cardiorespiratory stability for that. And I've been using that a lot now. So I've had patients in pre-admission that I mentioned on a text message to Sam, a patient that was knocked back for having a very, very high blood glucose because he just basically let everything go and stopped taking his metformin because he heard something on a dodgy podcast. And so I said, "Look, we can't do it today." And then I worked through, again, I offered him, and he consented to hypnosis just in the bay in front of everybody else. He's induced, off it goes. I took him to the pictures and got him to watch a movie of a better life, and I described it in great detail. And again, he woke up. And the key phrase he said was, I can tell that you're not just doing a job, that you really care about me. And I almost get a lump in my throat at the same time, because it's easier just to say, your sugar's too high, you lazy bastard, go home. And often you see cardiology letters, I have instructed the patient to lose weight. And then what? And then I instructed him to leave my office. And learning lifestyle medicine actually enables you to take it that extra step. And as you get more and more experience, you will refine that down so it need not take too much more of your time. And then, we have certain ceremonies that we have in medicine. We don't always need to listen to the chest. It's just a bit of a dirty secret. It's actually a ritual. The patient knows that you've done something, you've laid on hands, you've put an instrument on. When you've got an echo report from 3 days ago, you don't need to listen to the murmurs. So we do things that are rituals anyway. May as well make it something that's useful to them with some information they can take home. And the expression that the man said, who said, I can tell you looking after me, was, I feel like I've just seen a movie of a better life and you were narrating it, and now I know what to do. So he's fully pumped to it. You go, and I said, you need to go to your doctor this afternoon or tomorrow and get some rapid glycemic control. And then here's a discount site for a Dexcom for wear that for a month so you know what's going on. And I listed a whole other list of things that he can do. And so he's actually got something from a patient that I've just cancelled surgery for, when they'd normally complain and write a nasty letter. He sent me a text message thanking me. And then also the mind-body connections. As I intimated, I've recently learned hypnotherapy because I accidentally hypnotized a patient in a cataract list, and then I went on to the JCU Lifestyle Medicine alumni WhatsApp and said, does anybody know any doctors who are not into purple crystals and anything woo-woo? I want to see if someone can teach me this. And I was put on to a now retired anaesthetist, Michael Goldblatt, who put me onto some courses. And it's been remarkable in just enhancing the empathy of my care, to understand that everything you say gets in. Everything is remembered, even if it is not recalled. It can be remembered recalled in other ways, in other somatic ways and non-conscious ways. And make me very, very conscious of nocebos. I mean, the patient knows you're going to stick a needle into them. They don't need you to tell them it's going to hurt. They know they're having an operation. They don't need you to tell them they might have pain. Why don't you let them make their own mind up how they feel about it? And then you can you just have a consciousness for how comfortable you want them to be. If you're not as comfortable as you like to be, we can give you some medicine to make you more comfortable. If you don't feel like eating as soon as you wish to eat, we can give you some medicine to make you feel like eating sooner. It's all about the positive side of it. Like I said, they're not idiots. They know they're having needles and operations. Saying sharp scratch, just a mozzie bite. It's not a mozzie bite. It'd be a Jurassic Park mozzie. And then finally, almost finally, self-care, as has already been mentioned. It's enabled me to look at my own life and improve my own household, and to, we have bread in the house, but we make it ourselves. We have yogurt, we make it ourselves. We're making sure that we can have as much whole food as possible, and that we get as much exercise as possible within the constraints of all of our injuries. It's just improved our whole family dynamics, just knowing the general implications of our life choices. And finally, side hustles. So I don't always want to be an anaesthetist, and I had looked at, like my hypnotherapy mentor, of doing that more as I could progress through medicine. But you know what? Blending that with health coaching is the obvious choice, because then you can use the hypnotic techniques and suggestions and motivational techniques to blend into one, transition into a different type of medicine. And then I can practice as a doctor for many, many, many more years, because when I go to work every given day, I bring 5 to 10 patients close to death. It's the nature of my job. It gets on your nerves. So this enables me to practice a different kind of medicine, a slower kind of medicine. And I don't like the word holistic, but it is a more holistic kind of medicine that treats the whole patient as someone to optimize their wellness for, rather than just treating a disease with a substance that has side effects. Yeah, that's me. And I'll hand over the next speaker.
My name's Dr. Bethany Huff, and I'm a GP based in Bendigo in central Victoria. And I've also completed my Masters of Lifestyle Medicine. So I finished that mid-year this year. First of all, I'm going to tell you a little bit about about myself and why lifestyle medicine, and and about the masters, like Emma and Michael have also done as well. And then I'm also just going to run you through a very brief synopsis and a brief version of what my final master's project was, which was looking at the lifestyle management of pain associated with endometriosis. As I mentioned before, I'm a GP, and I think I was frustrated with some of the current constraints in general practice, and I really wanted to um, be able to offer more holistic and well-rounded care. But I really wanted to know where the evidence base was. I think some of the others have also mentioned how some of these when you look at lifestyle medicine, and lifestyle, there's a lot of different people online that are promoting this, but actually, where is the evidence? And I wanted to make sure that if this is the niche area that I'm really interested in, I really want to be practicing evidence-based medicine. And then that got me Googling and looking up, and I found out about James Cook University and their lifestyle medicine courses. So initially, I enrolled just for the grad cert, but loved it so much they turned it into the graduate diploma and then into the masters. And I like telling people that studying this masters has been the first time that I've enjoyed studying anything since I did year 12 maths. So I think, really, really have enjoyed the study and learnt a lot. And it's really shaped where my career is and hopefully where my career is going into the future. So I think just different opportunities that have been open to me since doing this. So as Emma alluded to, I've been doing some work for an online tech and health company called Everlab, which has been really interesting, kind of seeing different models of care. And this is all focused on preventative health and being able to really utilize my lifestyle medicine skills and some of the health coaching skills and things like that. To a motivated population. And it's been really good to utilize that. But I think also working in the online space has also made me realize how much I miss and love working in my local community and really serving the needs of those around me. So actually, just over the last few weeks, I've officially launched a little lifestyle medicine clinic locally. So just a day a week initially, but my plan is to try and complement regular general practice. So not taking over the care of their regular GP, but really offering longer appointments and having the time to do some of the health coaching, motivational interviewing, and behaviour change that I found was really challenging to do in a 15-minute consult. So that's just up and running, and really looking forward to seeing how that grows and develops and changes as it moves forward. So that's kind of where I'm at the moment. But now I might share my screen and I will start talking about my master's project. So like I mentioned, my final project in my master's was looking at the evidence on lifestyle interventions for the symptom management of pelvic pain in women with endometriosis or adenomyosis. And this was a scoping review. And I did it under the supervision of Sam, and then also obstetrician gynecologist Natalie Drever, I was very much appreciative of their support throughout this. So first of all, just some background into endometriosis and adenomyosis. So both of these conditions are chronic inflammatory conditions. So with endometriosis, you get endometrial lesions outside the endometrial cavity, and this can lead to a whole range of symptoms, but particularly things around chronic pelvic pain. So dysmenorrhea, chronic pelvic pain, dyspareunia, so pain with sex, pain with bowel motions, but then other symptoms such as fatigue, infertility, and heavy periods as well. And this has a significant impact on health and quality of life. And it's really common. So 1 in 9 Australian women are diagnosed with endometriosis by the age of 44. So it's a really prevalent disease. And current management is really focused on surgical, so excision, hormonal treatments, so things like the pill or progesterone, and then also analgesia. Adenomyosis, again, it's an inflammatory condition, but this time the endometrial tissue grows inside the myometrium, so inside the muscle of the uterus. And again, symptoms it can cause chronic pelvic pain, heavy periods, infertility, and its prevalence is less well known, but some studies have shown up to 60% of people may end up actually having adenomyosis. But again, the current management is mostly surgical or hormonal. some of the current issues with this management. So we know that there's a 50% discontinuation rate for some of the hormonal treatments because of side effects. And it's actually unclear whether the excision of endometriosis improves the pain. And I think some of these statistics, when I learnt about them in the graduate diploma part of my master's, got me really, really thinking, which I think led into this project. So I think particularly when you think about this, so 54.6% of women with endometriosis are unsatisfied with their medical care, and 76 of Australian women with endometriosis are then utilising self-care and lifestyle choices to try and manage their pain. Yet the previous endometriosis guidelines, which were published in 2021, contained half a paragraph in their 200-page document about what you could be doing as non-pharmacological and non-surgical management options. So I think that to me, this really highlighted a need. So where was the evidence? Because clearly these women with endometriosis were looking for lifestyle factors and other ways that they could help manage their condition, yet the healthcare system that they were in weren't providing that knowledge, and also didn't have the evidence to show them. So that's what I then went looking for. So as you're all aware, like lifestyle medicine is this application of environmental, behavioural, motivational principles, and including self-care and self-management in the management of lifestyle-related health problems in that clinical setting. It's a multidisciplinary field. And lifestyle interventions have been shown to reduce inflammation, and there is this emerging research in their role in chronic disabling inflammatory conditions such as rheumatoid arthritis or inflammatory bowel disease. So if there's evidence in these chronic inflammatory conditions, my hypothesis prediction was, hey, there might be evidence in other chronic inflammatory conditions such as adenomyosis and endometriosis as well. So then I got to my research question, which was, what is the evidence on lifestyle interventions for the symptom management of pelvic pain in women with endometriosis or adenomyosis? So I did a scoping review, which is really looking at the extent of evidence on a topic, and summarising those findings to try and identify any gaps in the literature, so then you can plan for future research. So I did a really comprehensive search of some of the most common search engines, and I limited to just English language, and I really and those over the age of 18. So I was focused on adults rather than the adolescent population, and I really tried to focus as well on self-management. So interventions that didn't require ongoing input from a medical specialist or allied health practitioner. So really things that people could then take ownership of and do in their own lives. So with my search that I did, my initial search came back with over 4,000 articles, and then Natalie and I reviewed and screened these articles, their abstracts, and then the full studies, and we ended up getting to 21 articles, which were included in my final review. So looking at this, they did range across some of the different pillars of lifestyle medicine, but there was no studies that I found that looked at either sleep or substance avoidance. There was a few studies on mind-body interventions, 4 on nutrition, 2 on physical activity as well. Most of these studies were not necessarily randomized control trials. So they were intervention trials that weren't randomized control. So I think when we're thinking about the level of evidence and things like that, again, further research really needs to be done in this area. Interestingly, 7 of the 21 studies were pilot studies. So I think this shows that there's a lot of interest in this space, and hopefully there's some more detailed studies that are going to be undertaken in the years ahead. Most of the follow-up time for these studies was less than 12 months. So again, it would be great to see some studies in the future with longer follow-up times, because again, these are chronic conditions that people have lifelong, but can cause symptoms throughout those reproductive years while they're menstruating. So really, it would be nice to see some longer follow-up rather than just 12 months. Again, quite a lot of the studies have been published in the last 5 years, I think, which again just highlights the interest in this area at the moment. So it's really exciting to kind of be part of this movement where there is a lot of interest and passion at the moment. So just a quick summary of some of the main positive outcomes that I found when looking at these studies. So looking at nutrition, there was some evidence for the role of the low FODMAP diet with dyspareunia, and this was particularly some women with endometriosis have a crossover with IBS and irritable bowel syndrome, and particularly with those women going on the low FODMAP diet did improve their pain outcomes. There was also then evidence for the Mediterranean style diet in pelvic pain as well. And I think particularly with this, it's then thinking of the anti-inflammatory kind of style diet. So trying to aim for those whole foods, less processed foods can really show to have impact in these inflammatory conditions. Looking at the physical activity, there was evidence for this physio and NDA program in dyspareunia, particularly, and some general pelvic pain. And this program was like a 9-week long program that women participated in with their endometriosis. With Mind Body, there was evidence for endometriosis yoga on pain. So going through a set yoga program over a period of weeks really did have an impact on their pain level. There was actually mixed results with some of the mindfulness studies, with 2 of them showing positive impacts on the pain, whereas two of the studies showed no impact on pain. But with this, it was interesting to then look at the demographics of the women that participated in the studies. So actually the 2 studies that showed impact on pain, those women had their chronic pelvic pain and their endometriosis for a much shorter period of time for the 2 studies that didn't show any impact on their pain. So again, I think when you're thinking about neural pathways and things like that, actually some of these neural pathways, if they've had pain for a long time, it's going to take a long time to try it may take a long time to kind of get on top of that and rewire some of those pathways. So my prediction would be that actually maybe some of these mind-body interventions would actually work if they were provided for a longer period of time, particularly in those populations that have had their pain for a long period of time. There was also some other interventions that don't necessarily always fit under the classic pillars of lifestyle medicine. So things like TENS and the evidence of TENS on chronic pelvic pain. So using TENS during the time when women are menstruating and having their periods showed positive impact on their pain there. And then, using some different endometriosis apps as well, which provided a combination of kind of education across different lifestyle domains and resources for women to be able to track their symptoms as well. So I think putting all of that evidence into practice, I've then kind of developed, if I had a woman with endometriosis in front of me, what are the type of things that I kind of would recommend to her that we could be doing to help manage her pain from a lifestyle perspective? So I think looking at her at nutrition, I would recommend going on an anti-inflammatory or Mediterranean style diet. And with that, it would be potentially linking in with a dietitian and providing handouts to really optimize that, particularly if they had some symptoms of irritable bowel syndrome or other bowel symptoms. Something like the low FODMAP diet would also be beneficial for these women. Looking at physical activity, I'd recommend an 8-week personalized strength and aerobic exercise program, again with an exercise physiologist or a physiotherapist, and again to help to improve their pain. I would recommend doing a mindfulness-based program and continuing to practice those mindfulness-based interventions throughout their life, and similarly a yoga program and continuing to practice yoga as well. Women are you can purchase TENS machines online and things like that, and I actually think that could be really useful for women that are in significant pain and get significant dysmenorrhea, that using a TENS on the parasacral region for 20 minutes twice a day during the time that they're menstruating can improve their pain at that time. And then they could also utilize some of these apps that are available as well, such as the Endo app. As I mentioned previously, none of these interventions looked at sleep and substance cessation, and this is despite endometriosis, people with endometriosis often having low quality sleep and high levels of insomnia. So I think you could suspect that actually some targeted interventions trying to optimize sleep might also help to reduce some of that inflammation and some of the pain response and improve their outcomes as well. Similarly, reducing the amount of alcohol reduces inflammation, and you could suspect that that might reduce some of their pain as well. The other really interesting thing was actually in those studies that we screened for, adenomyosis was only included as a diagnosis in one of these studies. So really everyone was just focusing on endometriosis rather than the adenomyosis. So it'd be really great for future studies to include adenomyosis as well as the endo. And like I mentioned before, having a longer follow-up time as well. And I think a lot of the studies also just focused on kind of one of the pillars of lifestyle medicine, but I think as we've been talking about, it's kind of that whole person approach and looking at all of the other pillars. So it'd be really interesting to see some interventions that are really multimodal and utilizing all of the different pillars of lifestyle medicine. So yeah, in conclusion, with my scoping review, I retrieved 21 different articles. They varied in design, numbers, and follow-up, but they did illustrate potential effectiveness with dietary changes, physical activity, brief mindfulness interventions, yoga, multimodal programs, and TENS. But really, we do need some bigger numbers, bigger studies with more participant numbers to really draw some more definitive conclusions. And my research also only focused on the domain of pain. And there's a lot of other, as I mentioned at the start, women with endometriosis experience a lot of other symptoms with decreased quality of life, fertility, mental health, in addition to the pain. So also broadening out some of the research to cover those other domains will be really important as well. I think, fortunately of note, there was new endometriosis and adenomyosis guidelines released in May this year. I think they were released the same week that I submitted my my final master's project, and these actually did include, fortunately, some recommendations for the lifestyle management of endometriosis. So again, it talks about the importance of physiotherapy and physical activity, how doing some mindfulness-based interventions. You could consider the low FODMAP diet, and then yeah, things like acupuncture as well can be recommended. So that's all. Thank you, everyone.
Thank you, Bethany. And thank you, Emma, and thank you, Michael, for your excellent presentations. It's really heartwarming and inspiring to hear everything everyone's done in this field, and it is just so wonderful to be part of that journey. So, thank you for presenting tonight, and it's been an absolute pleasure. I think we've got no questions. So I think, interestingly, despite us all going over our time, I think we can actually wrap up before before time. So that's good. So I think we got no questions because we must have just done such a great job at answering everyone's questions. Nice, got some nice comments though. Very inspired. Thank you very much. Okay, so I think therefore we could probably just wrap this up. So thank you everyone. There you go. No questions from my end, but I really enjoyed Michael's take on hypnosis. Yes, it is fascinating, isn't it? Thank you all for a great session. Wonderful to hear. Thank you. So yes, I hope you all found this a valuable and informative webinar. It gives you a really good idea as to the various options you can take in this field, the sort of excitement that goes with creating and being part of a movement like this, and implementing it in where you feel most meaningful, and where you care about. So I think and also as was highlighted, that improving your health, hopefully in the process, and improving your connection with your peers and other things like that in the process. So thank you once again, everyone. This will be recorded and sent out. And thanks again to Bethany, Michael, and Emma. And you all have a lovely night.